Okay, let's start with vascular disorder in Love and Bailey, chapter 62, venous disorder. Introduction. Up to 40% of the adult population in resource rich countries have disease of the veins of the leg. This extraordinary prevalence, along with the associated impairment in health related quality of life, make it a very important area of surgical practice. Surgical intervention has been revolutionized by the development of endovenous technique, and the level of one evidence has demonstrated that treatment can be associated with very high clinical and cost effectiveness despite the considerably importance placed on lower limb functioning during the management of orthopedics and arterial disease. Venous disease are often forgotten or dismissed as cosmetic practice. An understanding of the nature and management of venous disease is critical to address this imbalance and improve the quality of patients' lives. The anatomy of the venous system of the lower limb. The venous system of the lower limb can be divided anatomically into the superficial venous system and deep venous system. Beneath the deep fascia of the leg, deep vein system, accompanying the arterial tree, the superficial veins drain into the deep venous system either at junctions or via fascial perforating veins, and the deep veins then return blood to the right atrium of the heart. Venous anatomy is characteristically variable. The terminology used below is consistent with international consensus. The deep veins of the lower limb include three pairs of vena comitan, which accompany the three crural arteries, anterior posterior tibial and peroneal arteries, anterior and posterior tibial and peroneal arteries. These six veins intercommunicate and come together in the popliteal fossa to form the popliteal vein, which also receives the soleal and gastrocnemius veins. The popliteal vein pass up through the adductor hiatus to enter the sub subsartorial canal as the femoral vein, which receives the deep femoral vein or profunda vein, deep femoral vein or profunda vein in the femoral triangle before passing behind the inguinal ligament to become the external iliac vein. The internal iliac vein combines with the external iliac vein in the pelvis to form the common iliac vein. The left common iliac vein passes behind the right common iliac artery to join the right common iliac vein on the right side of the abdominal aorta to form the inferior vena cava, which goes on to the right atrium. Far more anatomical, let's see image 62. Anatomy of the deep veins of the lower limb, anatomy of the superficial veins of the lower limb, great saphenous axis, anatomy of the superficial vein. This is anterior tibial vein, this is posterior tibial vein, this and the middle one is peroneal vein. This combines and make popliteal veins. Popliteal veins goes up, and then above popliteal fossa superficial femoral vein, then combined with profunda femoral vein, then it's called saphenofemoral junction saphenous vein, then above this called common femoral vein. This is the posterior on B, anatomy of the superficial veins of the lower great saphenous and small saphenous. This is here is great saphenous vein, medial at the medial malleolus. This is the course of GSV, great saphenous vein, and common saphenofemoral junction. This is a short saphenous vein, posterior side of leg, small saphenous vein, saphenopopliteal junction (SPJ), cranial extension of small saphenous is called Giacomini vein. Giacomini vein. Okay. exist within the superficial veins of the lower limb, but there are almost always two trunks or axes, the great and small saphenous vein. This lies superficial to the fascia lata, superficial to fascia lata, but deep to the saphenous fascia in the saphenous envelope. As the sole of the foot is often placed under significant pressure. The majority of the venous drainage of the foot is into the dorsal venous arch, running in the subcutaneous tissue over the metatarsal heads. The medial end of this arch drains into the first axis, the great saphenous vein. This is the longest vein in the body and is the most frequently affected by superficial incompetence. The GSV passes anterior to the medial malleolus and ascends the leg accompanied by the saphenous nerve in the superficial tissue medial to the tibia, looping posteriorly at the level of the medial condyle of the femur and continuing in the medial thigh. In the groin, it unites with tributaries corresponding to the arterial branches of the common femoral artery before piercing the cribriform fascia covering the saphenous opening approximately 2.5 cm below and lateral to the pubic tubercle. This is location of SFJ, saphenofemoral junction, but often somewhat higher and terminates by draining into the common femoral vein CFV at the saphenofemoral junction. Throughout its course, GSV unites variably with other superficial tributaries. The anterior accessory of great saphenous vein AAGSV is one of the most common. This is often seen originating around the lateral border of the knee, although it sometimes originated as low as the lateral end of the dorsal venous arch. Okay, मतलब foot जोड़े हुए. Occasionally, these veins may also course up the medial aspect of the thigh anterolateral to GSV and following its course. In this instance, its origin is typically a confluence of small tributaries around the knee. There is usually an inline GSV axis passing uninterrupted from the foot. In some cases, this may hypoplasty, but this pattern of AAGSV is commonly mistaken for the GSV itself. Some surgeon will call this a duplex GSV. Duplex GSV, AAGSV. A true duplex GSV is rare. The AAGSV may drain into the GSV in the thigh, but is typically at or near the junction itself. The small saphenous vein originate from the lateral side of the lateral side of the dorsal venous arch and accompanies the nerve sural nerve. Is it passed posterior to the lateral malleolus, then upward in the posterior midline of the leg. In the proximal calf, it is usually found sitting in the groove between the two muscular heads of gastrocnemius. Its termination commonly occurs by piercing the fascia of popliteal fossa to drain into the popliteal vein at the saphenopopliteal junction. However, this junction is highly variable and the vein may terminate as low as the mid calf. The SSV may extend cranially beyond the SPJ, in which case it is known as either a cranial extension of the SSV, which terminates by piercing the fascia in the posterior thigh to drain into a deep system, or the Giacometti vein, which communicates with the GSV system, occasionally joining the GSV at or about the SFJ. In some cases, the SSV does not terminate at or below the popliteal fossa at all, but continues on a described above. In the calf and the thigh, there are a number of valved perforating communicating veins that join the superficial to the deep veins at inconstant sites and which allow blood to flow from the superficial to the deep system. The most important of these are the direct perforating veins of the medial and lateral calf. And the communicating veins around the knee and in the mid thigh. Venous pathophysiology. The purpose of the venous system is primarily to return blood back to the heart so that it can be delivered into the pulmonary circulation. The venous system contains approximately 60% of the total blood volume with an average pressure of around 5 to 10 mmHg. Mechanical factors alongside the autonomic nervous and endocrine system control the rate at which blood is delivered to the right atrium. Through its effect upon myocardial contractility via the Starling mechanism, venous return is one of the factors responding for the determining cardiac output. Blood enters the lower limb through the femoral arteries before passing through arterioles into the capillaries, which which have a pressure of 32 mmHg at their arterial ends. This pressure is reduced along the course of the capillaries and is approximately 12 mmHg at the venular end of the capillary. The pressure continues to fall into the main veins and is as low as 5 mmHg at the upper end of vena cava, where it enters the right atrium. The venous pressure in a foot vein on a standing is equivalent to the height of a column of blood extending from the heart to the foot, approximately 100 mmHg. To enable blood to be returned against gravity in the standing position, a pressure gradient must exist between the veins in the leg and those in the chest. Between the leg, okay. This gradient is created in two ways. First, the increase in thoracic volume during inspiration decrease, decreases intrathoracic pressure. Second, the pressure in the veins of the leg is increased by compression by surrounding calf muscle pump, and to a lesser extent to tone of the venous valve. The deep veins of the calf are capacious and are joined by blind ending sacs called the soleal sinusoids, which force blood into the popliteal and crural veins during the calf muscle pump contraction. Walking. The foot pump also ejects blood from the plantar veins during walking. As the calf muscle contracts, the veins are compressed and the valves only allow blood to pass in direction of the heart. The pressure within the calf compartment rises to 200 to 300 mmHg during muscle contraction. Okay. Rapid blood flow in the deep veins at junction and perforators draws blood from the superficial veins, driving this up to the deep veins also. During muscle relaxation, the pressure falls and further blood from the superficial veins enter the deep vein. Each time this occurs, the pressure falls in the superficial venous compartment until a threshold is reached. When the venous inflow keeps pace with ejection from the deep veins, this is normally 30 mmHg. A fall of approximately 2/3, मतलब 100 માંથી 30 થઈ ગયું એટલે 2/3 the resting venous pressure. The net reduction in the pressure of the superficial system is dependent on the presence of a pressure gradient between the leg and the thorax and a patent and compliant venous system containing competent valves. An absence of one or more of this result in venous hypertension, which leads to further vein wall damage, including loss of compliance, thickening, dilation, and valvular dysfunction. This venous damage goes on to reduce the function of affected veins, worsening the venous hypertension in a vicious cycle. When exposed to high venous or capillary pressure chronically, the soft tissue of the leg will be damaged, causing a spectrum of damage that becomes irreversible. The cause of venous hypertension are listed in this table. Factors causing venous hypertension: pressure gradient dysfunction and dysfunction of venous system. Pressure gradients increase abdominal or thoracic pressure and decrease calf muscle. Because of these two reasons, there has to be normal function of leg. So first is increase abdominal or thoracic pressure, and second one is decrease calf muscle pumping. Increased abdominal thoracic pressure, COPD, patient continuously coughing, pregnancy, obesity, large tumor, and constipation. Decreased calf muscle pump function in immobility, ankle joint fusion, paralysis, dysfunction of the venous system, venous structural deficit, venous occlusion, venous compression. Venous structural deficit, valvular agenesis, valvular incompetence, venous dilation, venous tortuosity, loss of venous compliance, loss of venous tone, arteriovenous fistula, venous occlusion, agenesis, thrombosis, iatrogenic trauma, venous compression, May-Thurner syndrome, pelvic abdominal tumor, pelvic abdominal radiotherapy. Now, the majority of patients with venous disease have a problem primarily with the vein wall structure and is in most diseases conformed to the superficial veins. Little is known about the mechanism of initiation of the change in the vein wall. These changes are complex but are typified by the valvular failure following the retrograde flow within the vein with gravity venous incompetence. It is no longer thought that venous incompetence is caused by a primary mechanical valvular failure. The vein wall change include inflammatory cell infiltration and activation, dysfunctional smooth muscle cell proliferation, collagen deposition, decreased elastin content, and increased matrix metalloproteinase. વેન વોલ ચેન્જીસ કેના લીધે થાય છે તો dysfunctional smooth muscle cell proliferation, collagen deposition, decrease elastin, increase matrix metalloproteinase, matrix MMP. These effects typically leads to loss of compliance, dilation, elongation causing tortuosity, and secondary valvular dysfunction. This process can be initiated anywhere in the venous tree. Secondary varicose vein may develop in patients with post-thrombotic limbs and in patients with congenital abnormalities such as Klippel-Trenaunay syndrome or multiple AV fistulas. Image is varicose veins. A left leg varicose vein in the distribution of incompetent GSV veins marked for intervention. Right leg posterior side માં છે varicose vein distribution of small saphenous vein with a recent episode of phlebitis. Varicose vein in the distribution of an isolated incompetent anterior accessory of great saphenous vein with associated gaiter area skin changes. Okay, this goes from lateral to medial. Okay. The extent and number of incompetent veins governs the extent of venous hypertension and correlate with the severity of soft tissue complications. Importantly, however, neither the reflex burden nor the presence of skin changes short of ulceration correlate with the presence or degree of symptoms. Clinical features of venous hypertension on the leg. Following features commonly seen: varicose vein, subcutaneous dilate. This is definition: subcutaneous dilated veins 3 mm in diameter or larger. They are frequently elongated and tortuous with intermittent blowouts, but are defined by the presence of reflux and may be straight and uniform tubes morphologically. What is telangiectasia? Telangiectasia, thread veins, spider veins, and hyphen webs represents tiny intradermal venules less than 1 mm in diameter. 62.4. This is telangiectasia and reticular veins. This is Saphina varix. Advanced skin changes, lipodermatosclerosis, eczema and atrophic blanchy, pigmentation, hemocitosis and mild eczema, severe eczema, and this is hemosideration, mild lipodermatosclerosis of the calf skin. Reticular veins, small dilated bluish subdermal veins 1 to 2.9 mm diameter. First is less than 1 mm, that is telangiectasia, thread veins, spider veins. Okay, and then reticular veins, those are 1 to 2.9 mm diameter, and varicose vein more than 3 mm diameter. Usually, tortuous can be difficult to distinguish this from a normal subdermal vein in someone with white, thin, transparent skin. Okay. Safina varix is usually painless, groin swelling apparent on standing. Corona phlegmaticia, malleolar flare, a fan-shaped pattern of telangiectasia at the ankle or foot. This is an early sign of advanced venous disease. Edema, increased volume of fluid in the skin and soft tissue of the leg, commonly starts distally and move more proximally with increased venous dysfunction. Classically, this is pitting edema with firm digital pressure leaving an indentation in soft tissue. Eczema and erythematous dermatitis often appears minor, although it may be associated with significant itching and discomfort. In extreme cases, it may progress to blistering and weeping. Pigmentation, hemosiderosis, a brownish discoloration of the skin, usually permanent. It is usually seen around ankle, but is also seen proximity to varicose veins and incompetent perforators. Lipodermatosclerosis, LDS, chronic inflammation and fibrosis of skin, subcutaneous tissue, resulting in a tight, contracted, woody leg on examination. Lipodermatosclerosis, chronic inflammation and fibrosis of skin and subcutaneous tissue, resulting in a tight, contracted, woody leg on examination. It occasionally results in significant contracture of the Achilles tendon. This is a sign of severe chronic venous disease. Atrophic blanche, localized area of atrophic white skin, often surrounded by telangiectasia pigmentation. Some authors distinguish this from the white scarring left by ulceration. Others do not. Either way, this is a sign of severe chronic venous disease. Venous ulcer, full thickness skin loss, usually around the ankle, which fails to heal spontaneously and is propagated by continuous venous hypertension and the changes associated with chronic venous disease. Classification system, that is SIP classification, clinical, etiological, anatomy and pathophysiology. Classification for chronic venous disorder is widely utilized. This is venous ulcer. For clinical classification, C0, 1, 2, 3, 4, A, B, C, 5, 6. No sign of venous disease. C1, telangiectasia or reticular veins. C2, varicose veins. C3, edema. C4, A, pigmentation or eczema. 4B, lipodermatosclerosis or atrophic blanche. L4C, corona phlegmaticia. C5, healed venous ulcer. C6, active venous ulcer. Clinical class can be further characterized as symptomatic, asymptomatic और रिकरेंट, मतलब सिम्टोमेटिक है तो S, एसिम्टोमेटिक है तो A. C2A, C2C, C6 है ना. R for recurrent following previous successful treatment, this is called R. For etiology, CPSN CPS and CPS congenital, primary, secondary, and no venous cause identified. For anatomical, SPD. લાસ્ટમાં નો બધામાં છે SPD, superficial vein, perforated vein, deep vein. There is 25 minutes done.